Good morning. I'm Dr. Melissa Hardesty. For those of you that don't know me, I work with Dr. Hope and help take care of the gynecologic cancer patients here in the state of Alaska. Most of you know that I I have interesting ways of expressing myself, so I just have to say that um, the panel of speakers that we have today that I have the pleasure of introducing you to, I'm sure that I'm not going to do them credit with the um, amount of accolades and wonderfulness that they have contributed to the field of GYN oncology. They are all just absolutely outstanding with resumes that are very impressive and have contributed so much to our understanding of how we take care of women with these cancers. And so much has changed that these presenters are taking time away from their crazy schedules, many of whom are actually at a big research meeting in Florida right now, which is where basically people with expertise gather together and decide what's going to be happening next in the world of clinical trials. And it's kind of like the birthing ground for these trials, and they're taking time away from that craziness, to give their time to help us here in Alaska make sure that we're able to apply the research that they have painstakingly performed and bring those advances here to the women of Alaska. So I can't say enough about it. The very first speaker was actually a person that I trained with maybe not that many years ago, not that long ago, Dr. Kathleen Moore. And she is going to start off our conference talking to us about a category of medicines that many of you are familiar with called PARP inhibitors. In addition to the fact that Dr. Moore is the director of the phase 1 clinical trial program at her institution in Oklahoma, she was the lead author on what was really the most remarkable landmark paper looking at this category of medications and their use in people who have hereditary predispositions to ovarian cancer. And that paper really changed the landscape in a bedrock way for the first time in many years. So we have the great honor to hear Dr. Moore update us on this category of medications, which is called PARP inhibitors. With that, I'm going to let Dr. Moore's presentation begin.
Hello, everyone. My name is Dr. Kathleen Moore, and I am a GYN oncologist. I am the Associate Director for Clinical Research and Director of Phase 1 Clinical Trials at the Stevenson Cancer Center in Oklahoma City. And it's my great pleasure to have been invited to speak at the Let Every Woman Know conference. And I'm going to talk about PARP inhibitors, use of PARP inhibitors in ovarian cancer today, and kind of give an update because things have been changing as to what the current recommendations are for use. These are my disclosures. I think probably, so PARP inhibitors aren't new. So many of you in the audience are aware of them. There are 3 that are approved for use in ovarian cancer. I will be referring to them by their generic names: olaparib, which you may know as Lynparza, rucaparib, which you may know as Rubraca, and niraparib, which you may know as Zejula. Most of the time, I'm just going to say PARP inhibitor, though, because they're all relatively the same. And we've been studying them for a long time, and they have been approved for use increasingly in different populations since 2014 in ovarian cancer. But in 2017, I got to present Solo 1. In 2018, the first approval in frontline came out. And then in 19 and 20, we had sort of a just landslide of frontline treatment of ovarian cancer data that really changed the landscape for use of PARP inhibitors in the treatment of frontline ovarian cancer. And so in 2020, the American Society of Clinical Oncology, or ASCO, put out what we call a practice guideline. And I'm on this committee. There's 16 of us, and we evaluated all the evidence, prospective studies in the recurrent platinum-resistant, recurrent platinum-sensitive, and frontline, and came up with practice guidelines for how PARP inhibitors should be integrated into the care of women with ovarian cancer and gave guidelines based on the strength of evidence. And we asked these kind of questions that were outstanding at the time. This was 3 years ago, concerning, can we repeat PARPs? Are there certain patients who should or shouldn't get a PARP inhibitor following response to chemo and frontline treatment? Should you use PARP inhibitors instead of chemotherapy? There wasn't data for that at that point. What about combinations and toxicity? So there was this guideline. It was very well done, if I do say so myself. Bill 2 led it, and it was a very nice guideline for a few years. But in 2022, I'll start. So, and this is a figure from it, from the 2020 guideline. And this sort of set the standard of use for 2020 to 2022. And so what you can see here across the top is kind of the possibilities for where you might use a PARP inhibitor in frontline with chemotherapy with or to follow bevacizumab. You add in a PARP inhibitor, or just PARP inhibitor monotherapy as maintenance. In a platinum-sensitive recurrent tumor that has responded to platinum, PARP inhibitors can be used as maintenance. And then in the recurrent setting, either platinum-sensitive or platinum-resistant, can PARP inhibitors be used instead of chemotherapy? And so in the middle of this figure, you'll see the boxes in gold were the recommendations that at the time, 3 years ago, we felt were strong recommendations. And so those included use of PARP inhibitors, or consideration of PARP inhibitors as maintenance therapy following response to frontline chemotherapy, and that could be with or without bevacizumab for tumors that were homologous recombination deficient, test positive. Or we felt that in the platinum-sensitive recurrent setting, that PARP inhibitors could be considered instead of chemotherapy based on some clinical trial data. So we gave that a gold box. And then the last gold box is for use of PARP inhibitors as maintenance in the platinum-sensitive recurrent setting. So that's defined as a patient whose tumor has recurred, and it has recurred at least 6 months, if not longer, since they completed the first or even second carboplatin. And then they get treated with carboplatin again, and it responds, goes away, or shrinks. Then you can start a PARP inhibitor maintenance, any of the 3 I mentioned, and you would continue that for as long as the disease was under control. Those were all recommended. Things in green, only one thing in green was a maybe used. Said you can or you can't. The data was kind of meh, was for tumors that are resistant to platinum, but a patient may have a BRCA mutation, either they're born with it and it's germline or it's in the tumor, and they had never seen one. Then you could consider a PARP inhibitor in that setting. That was a maybe used. So those were the guidelines for a few years, and people really liked the simplicity of that. But in 2022, we knew that the Athena trial was being presented, which was the frontline study of the PARP inhibitor Rubraca, or rucaparib. It was very similar to all the other studies. It was patients with newly diagnosed ovarian cancer who were in response to their first combination of surgery and platinum-based chemo, and they were randomized to receive rucaparib or placebo as part of that study. And that was going to be, and it was positive. We knew the press release was positive, and it was going to be presented at the ASCO meeting in June of 2022. And so the guideline group was called back together to update our guideline because we wanted to include the Athena study. So we were waiting for that to come out. But at the time this was coming out, several decisions were made between pharmaceutical companies and the FDA to start withdrawing some of the indications for use of PARP inhibitors in the recurrent setting. And so we very quickly had to incorporate all of these into the updated practice guidelines. And these retractions were initially all the indications, the first indications that happened in 2014 and 15 of use of PARP inhibitor instead of chemotherapy in patients that had a BRCA-associated cancer, either born with it or in the tumor, who'd never received a PARP. They could use a PARP instead of chemo. All of those indications were withdrawn. And so those were no longer recommended. So I'll show you the update. So that was happening very quickly. And then they also started to murmur about withdrawing the biomarker negative tumors from platinum sensitive recurrent maintenance, which was the initial big phase 3 approvals in PARP inhibitors. So that group of patients who have recurred, but their tumors are still sensitive to platinum, and they get a platinum and the tumor shrinks, any patient in that situation could get a PARP inhibitor. The FDA and the pharmaceutical companies started withdrawing that indication for any tumor that wasn't BRCA. And so we had to very quickly adjust the guidelines, and I'm going to take you through why this happened so you understand the current, and it may change, get ready, but the current guidelines for how we recommend that PARP inhibitors be used to the best benefit of all of our patients. This is the figure now, so it looks a lot different than the one I showed you. It's the same kind of situation on the top with the different lines of therapy. In green are things that we can recommend. I don't know why we didn't use gold again, but we used green. Frontline has not changed. So for a patient who has newly diagnosed epithelial ovarian cancer, who's in response to their chemotherapy and surgery, niraparib or olaparib with or without bevacizumab, which you may know is Avastin, may be used. And I'll talk about those indications. We do list Rubraca or rucaparib here based on the Athena data, but that does not yet have FDA approval. And so I just have to say that it would technically be off-label. So that's still approved and nothing has changed. And we still, at the time this came out, said recommend PARP maintenance in the platinum-sensitive recurrent setting. That has since changed, so I've updated the slide. But no longer recommended at the time we wrote this, which was at the end of last year, it's already changed, are PARP inhibitors for treatment instead of chemo. So not as a maintenance, but if your tumor is sensitive to platinum and you used to say, well, you could get a platinum or we could use a PARP inhibitor. That's gone, is platinum. And specifically in platinum-resistant tumors, there's no more recommendation for PARP inhibitor either. So these are now red stop signs. And there will be more of these when we update the guidelines in 2023. So these are the recommendations, and I adjusted them a little bit. So for olaparib, this is Lynparza. It is approved by itself as a monotherapy for maintenance after first chemotherapy, only in tumors that have a BRCA mutation. It is still approved in the platinum-sensitive maintenance setting for any patient who responds to their platinum, irrespective of biomarker. So BRCA, non-BRCA, it's still approved. It's hanging on. Olaparib with bevacizumab, which is Avastin, is only approved in tumors that are HRD positive, and that includes BRCA. So HRD is a test we send on the tumor that tells us that tumor is likely to benefit from a PARP inhibitor, and it was the group that benefited the most from this combination. So you can only use this combination in that subset of patients, and it's not a regimen for the recurrent setting. Niraparib, you may know as Zejula, is approved for first-line maintenance in any patient, irrespective of biomarker, BRCA, non-BRCA, fine. In the platinum-sensitive maintenance setting, and this was the first indication for any PARP in a maintenance setting, was right here. It was the NOVA trial in 2016. In all comers, it showed benefit for what we call progression-free survival, but based on some concerns about overall survival, which I will show you in a moment, the FDA has withdrawn this. And so you can only use niraparib as a maintenance in the recurrent setting for BRCA. And Rubraca or rucaparib does not have an indication yet in frontline, although it's included on the NCCN guidelines. I haven't ever tried to get it. It would be considered off-label. I just want to say that from a compliance standpoint. But the benefit was across all biomarkers. We'll see what the approval, when it comes, looks like. I think that's a kind of a pending. I should have a pending there. But in the platinum-sensitive maintenance setting, similar to niraparib, it lost its indication outside of BRCA, and I will show you why. So the practice guidelines in 2022 really reinforce the benefit of PARP inhibitor maintenance in the front line. This is really where PARP inhibitors should be used. They're most effective here. They provide the most benefit, especially to tumors that are biomarker positive, either BRCA or homologous recombination deficient. And we have a stopping point, 2 to 3 years. And if the tumor is gone, you stop, as opposed to the maintenance setting where we treat indefinitely. They're on treatment forever. And that's important for a lot of reasons, but you can actually stop the therapy. So these are the 4 studies that have been done. SOLO-1 was only in BRCA-associated cancers and was just monotherapy, olaparib or Lynparza for maintenance. PAOLA-1 was all comers, including BRCA, bevacizumab plus olaparib. PRIMA was all comers, niraparib monotherapy, and Athena mono was, again, all comers. So when I say that, I mean not just BRCA. Any patient with epithelial ovarian cancer who was in response to their frontline chemo eligible for any of these studies, except SOLO. SOLO was just for BRCA. And across all of them, very consistent signals for really impressive benefits and progression-free survival, which is the time from starting the PARP inhibitor until the end of the study, or until someone progresses. And if you didn't progress, that's just the end of the study. So I'll show you what that means. There is increasing attention to overall survival, which of course we care about. We care very much about overall survival. But I'm going to show you some reasons why it's not always focused on in ovarian cancer, because it's a very hard metric to wait for in a clinical trial, because it happens years later. But we do actually have data now. SOLO-1 was done in 2013. So we have over 7 years of follow-up, and SOLO-2, which is in a recurrent setting, has even more. So we do have some overall survival data, and it is favorable for frontline use of PARP for 2 of these studies. And so that bodes well for us, and I'll show that to you. So this is overall survival. This is the time from entering the study, way back when a person was diagnosed and had finished their chemotherapy and started either PARP or placebo, until this is 7 years, 84 months, or death. That's overall survival. So, and a lot of these patients, hopefully you can see my cursor, all these little dots here on both arms are all this, what we call censored patients, because they're still alive. They haven't met the event rate in overall survival is death. And there's a lot of people still alive out here beyond 7 years, which is a good problem to have. So we actually don't have a final overall survival read on SOLO-1 because patients are doing so well. However, in addition to that, I think you can see from this curve in the blue, which is the olaparib arm, versus the gray, which is the placebo arm, that there is a significant difference. So even though we can't call overall survival like statistically finally read out, this is a really big difference at 7 years of patients who are still alive, 67% at 7 years who got olaparib first line versus 46% who did not. And the important thing to say here as well is that of the patients who are on the placebo arm, because PARPs weren't available off, as commercial agents when this was running. But once the study was done, in 2014 and 15, we had our first approvals. So they started to become available. So the patients who received placebo, about 44% of them at least, crossed over at recurrence or thereafter and received a PARP appropriately. So even with that use of PARP later, they didn't catch up in terms of overall survival. And so the message to the providers is that you shouldn't wait to use PARP inhibitors in a BRCA-associated cancer for later. I've heard that message, like I'm just going to wait and use it at recurrence. Well, the fact is a lot of patients don't recur, number one, if you give them a PARP. And number two, if they do recur and you haven't given them a PARP, yes, the PARP works pretty well in the recurrent setting, but you don't catch them up to the same survival as if you use PARP in the front line. So PARP in the front line, BRCA is a must. And now a patient can say, I don't want that. That's shared decision-making, and that's fine. People are their autonomous beings. But as providers, this is what we need to be offering. The overall survival at 5 years, so a little bit shorter. And for ovarian cancer, honestly, overall survival at 5 years is not long enough yet. But we did show this at this year for PAOLA-1, which was all-comer study with bevacizumab, olaparib versus bevacizumab, which is Avastin. And you can see on the left, in the all-comer group, which includes BRCA and then non-BRCA, the olaparib looks a little better. That's the green line, but it's not statistically significantly that much more. But in the right side, what you see is the group of tumors that are homologous recombination deficient. That includes BRCA, but it also includes about 20% of ovarian cancers that don't have BRCA, but their tumors still harbor these vulnerabilities to chemotherapy and to Parp inhibitors that makes them very responsive. And here we do see a statistically relevant difference at 5 years survival of 65 versus 48%. So there's clearly no detriment. I think we can say that across the board. And as we follow longer, there actually may be an overall survival benefit as we get out to 6 or 7 years, more to come on that. So we're seeing this across the board. I'm showing you, this is overall survival again for PAOLA in the BRCA group at 5 years, looks very similar. That's on the left, looks very similar to SOLO. So I expect a lot of these patients are cured. I'm going to show you that in a minute. And then in the middle is that group of patients that are not BRCA, but have these vulnerabilities, 55 versus 44% alive at 5 years. And then there's the group of tumors we really have to work on. And these are tumors that don't have that inherent vulnerability to how their tumor fixes their DNA. And so if your tumor is really good at fixing DNA as it replicates, it's going to fix the DNA damage we cause with carboplatin or Parp inhibitors and become resistant to it. So these tumors are problematic, and we recognize that, and we're working really hard to overcome this. So Parp inhibitors versus Parp inhibitor bevacizumab in this case versus bevacizumab, there was absolutely no difference, which is why it's not recommended in this setting. But I mentioned cure. So overall survival is important, 100%. We want people to be alive for a long time. But now I'm greedy. We're all greedy. Not only do I want you alive at 7 years, but I want you alive without recurrence, without 7 years of treatment. That's the goal. And we're not there for everyone yet, but we are starting to see glimmers of hope. So this is from SOLO-1. I showed you the overall survival. So that's just people alive. They could be alive and cured or alive on sequential therapies. This is the curves for who never recurred from SOLO-1. So what I'm showing you here is the placebo arm. And it is to say that at 7 years, 20% of patients with BRCA, at least those on SOLO-1, who were largely stage 3 and had a first surgery, kind of better clinical prognostic factors. But at 7 years, 20% of them are alive without progression. They have never recurred, and they're likely cured at this point. Maybe a few more recurrences, but they are likely cured. So 20% need nothing. And if we can identify them someday, that would be a great thing. So we don't overtreat patients. But when we use olaparib in the front line at 7 years, 45% of patients are still not only alive, but alive without recurrence. And on SOLO-1, we stopped the Parp inhibitor at 2 years, which is my recommendation, as long as you don't have evidence of disease. So these patients have been off therapy for 5 years, just living their life. So this is exciting. We have never seen this. And these patients are likely cured. Maybe a few recurrences, but we don't expect that. The majority of these patients are likely cured. So we're excited about this. The flip side is that 55% did recur. And so we're focused in on why they recurred, when they recurred, and how we can overcome that. And that will be in the next generation of clinical trials. So this is the new floor, the new expectation, and now we build from here. We've seen the same thing in PAOLA-1, because you might say, well, this is only for BRCA. What about, me? I'm not BRCA. So PAOLA-1, this is the HRD population that includes BRCA, but also includes those tumors that are not BRCA, but have some vulnerability. And at 5 years, the same thing, 19% cured. Now they did get bevacizumab, but 19% have not recurred. And probably a good fraction of those guys are not going to recur ever. And we're at 46%, no recurrence, potentially cured in this arm. So we are seeing this signal even beyond BRCA. We'll have to follow this. This is only 5 years of follow-up. Solo, we have 7. So we need to follow this a little bit longer, but this is pretty exciting. So are we starting to see the possibility of cure? You can see these kind of updated progression-free survival curves, because if you don't progress, the curve just gets flat, at the tail, and you kind of see that group of patients that are cruising along. We are starting to see fractions of hope here. HRD test negative tumors, as I mentioned, are another big focus. We have got to do better here. And you'll see some clinical trials starting to open in the near future that are specifically targeting this type of tumor to try and see if we can make these curves look more like these curves. So that's coming. PARP inhibitors help here, but they're not transformational. So we need to do better. I still think they're an option though, and it's just counseling between you and your physician as to whether or not this makes sense. But we do need to see overall survival data here. And so we've seen it for Paula, and I think the Paula approval, the solo approval we've seen, and that's solid. The Paula approval and HRD with that overall survival advantage, I think will remain. We're waiting to see these two, and Prima should be reading out pretty soon to see what overall survival looks like, not only in the biomarker positive subset, but also in that HRD test negative subset. If it looks about the same and there's no detriment, I believe that these approvals will remain and PARP inhibitors will remain an option versus bevacizumab versus other clinical trials or other options that your provider might discuss. It's not the standard of care, it's a standard of care. If it shows a detriment, however, to overall survival, then these two, the approvals in biomarker negative may go away. So I think that's something we're waiting to see, and that will, of course, force us to update the ASCO guidelines again. At this point, these are all still indications, but we are watching OS closely because we care about it, and that's the truth. So that's frontline, and that's where we should be using PARP inhibitors in frontline patients. I mentioned to you that the guidelines recently retracted the indications for use of PARP instead of chemotherapy in a platinum-sensitive setting. Why did that happen? Well, what happened is that these two studies, which were done, and their primary endpoint was progression-free survival, and both of them were positive and favored PARP, and that's why the indications were there, had subsequent follow-up of overall survival, which was never a primary endpoint. And I'll tell you why that's important in a moment, because there's a lot of missing data. But the FDA wanted to see overall survival, and it's very consistently worrisome for both of these studies, in that the colored bar lines on both of these are the PARP arms, and they have a lower overall survival than the cohort of patients who are randomized to chemo. And it looks to be about a 30% decrement in overall survival, very consistent between these two studies. And I'm going to tell you why this could be real. It's probably not. There's probably something in the middle. But because of the very consistent signal, there were retractions of these indications, and this is why this is no longer recommended. And I skipped through that. The same thing happened in platinum-sensitive maintenance in BRCA, non-BRCA. BRCA is fine. The overall survival looks better. In non-BRCA, in both the NOVA study and the ARIEL study, NOVA was niraparib, ARIEL was rucaparib, when they looked at overall survival, which was not a primary endpoint and not followed well, but be that as it may, the same thing was noted. About a 30% decrease in overall survival, very consistent across both studies. And because of that, the approvals outside of BRCA in a platinum-sensitive recurrent maintenance setting were retracted. So why do I sound kind of wishy-washy about it? Number one, I just want to emphasize, I care greatly about overall survival. Very, very much. We all do. But we don't want to make decisions based on false data. And so that's, I think, where we are a little puzzled right now. So it's either true or it's false. And it's probably somewhere in between. But statistically, why could this have happened and not be real? So 2 reasons. One is that overall survival in ovarian cancer is very difficult to assess because when someone's on a clinical trial, especially like second-line platinum-sensitive maintenance, and they progress on that maintenance, the post-progression survival tends to be very long, years. And so showing an overall survival benefit, or even looking at overall survival when patients are receiving many, many lines of uncontrolled therapy down the line, makes judging overall survival, even tracking it, quite difficult. Because there could be inequality in kind of what people get in each arm, because you're not controlling it once you're off the study. So post-progression survival and the subsequent therapies definitely impact how long someone lives. And then crossover is a big issue. So these are just 2 curves in statistics, so don't get scared. I'm going to explain it. On the left, this is a curve. On the bottom, this is the median survival post-progression. And on the top, and the y-axis is the probability of showing overall survival being statistically significant as a factor of how long a patient will live after progression. And so I expect patients to live like 2 or 3 or 4 years after progression. So we're already out to 24 months. The likelihood at any power of me showing a statistically significant overall survival is 20% right there. So it's already, you can already see the problem. And on the right-hand side, again, median survival post-progression on the x-axis, we're already 24 months. How many patients would I need in a study to really power it to show a difference in overall survival? 2,500, 3,000. It's not feasible. It would hamstring research and development, irrevocably. So these are the challenges we face with overall survival. They're good challenges because our patients live a long time and we want that. But the FDA is now holding us these overall survival benchmarks, which makes it somewhat troublesome. Crossover is also a challenge. So this is SOLO 2. This is platinum sensitive recurrence BRCA. Patients got a platinum and they responded. Then they got randomized to olaparib or placebo. This is before olaparib was approved. You can see on the left, olaparib looks better at overall survival. So it does, you can see it, but it was not better enough to be statistically significant. Why is that? Because of crossover. So if you look on the right-hand side, you see the olaparib curve, you see the original placebo curve, and then in dark black, you see the adjusted curve, which adjusts for the patients who appropriately got a Parp inhibitor when they progressed off placebo, which is what you wanted them to do. Like, that's not a criticism, it's what happens. So you want people to get the right care because they became available at that point. But if you adjusted the analysis just to compare to the patients who didn't get a subsequent Parp inhibitor, then it becomes highly statistically significant, 0.56. So I'm not arguing like, don't let patients cross over. I love crossover in studies. I love it. I think it's fairer. If you have progression-free survival as an endpoint and you end the study when that endpoint happens, let people cross over. I'm all for that. But then if you're going to judge me on overall survival, then I can't let people cross over. So that's the ethical conundrum with being held to overall survival and the impact of crossover on interpreting overall survival. I think crossover is a good thing because it improves overall survival in the comparator arm. But then if I'm judged on that, then it hurts my ability to get a drug approved. So you're in this like unwinnable situation. I also mentioned post-progression survival is long, and so patients can get variable things. And it also depends on where they live in the world. So this is an excellent example. This is Ariel 4, which was a study in treatment instead of chemo. So patients could have platinum-sensitive disease or platinum-resistant disease. They all were recurrent. They all had BRCA. And if they were resistant, they got rucaparib versus Taxol. And if they were sensitive, they got Rubraca versus carboplatin. And at the time of progression, there was one-sided crossover. So if a patient was randomized to chemo, they got to cross over to Rubraca, which I love. I thought that was brilliant and ethical. But here's what happened. When this study was running, Parp inhibitors were approved in the United States and in Europe, many parts of Europe. And so no one was with a BRCA mutation was going to participate in this trial. Why would they? They could get a Parp inhibitor. They were approved. But this study had to be done for the regulatory agencies. So it was done in places that have very limited access to therapies. Eastern European countries, as an example. And I love the physicians there. They're great physicians, but they don't have access to innumerable things to use for their patients. So what happened? They had this study open, and when patients progressed in the whole group, just lumping them all together, 19% of patients who were randomized to chemotherapy got no further therapy. And sometimes people are just too sick for additional therapy. That's a reasonable number, 19%. But in the patients who were randomized to Rubraca, 42% got no additional therapy. So right there, remember that crossover, that one-sided crossover. If you were on chemo, you could cross over to Rubraca and it was provided. If you were on Rubraca and there were no more options for your chemo, you just got nothing. And that's what we saw across the board. This is the platinum sensitive cohort. If you were on the Rubraca arm, 42% got no additional therapy, compared to patients who got chemotherapy, only 23% got no further therapy. Same thing, they have this partially platinum sensitive thing that's not really a thing, but let's look at platinum sensitive because this is the most disturbing. If you were on rucaparib, platinum sensitive disease, you got rucaparib and you progressed, almost 50% of patients got no additional therapy. They didn't even get platinum, probably because they just couldn't authorize it. Versus the chemotherapy arm, 85% of patients got additional therapy, and it was either platinum or Parp, two things that will work. So you can't tell me that when 50% of one arm doesn't get any additional treatment versus 85% of patients on the other arm get additional active treatment, that's not going to falsely skew your overall survival, which it did. So this isn't interpretable, which is why we're really frustrated about these retractions. But it is what it is. But this is why we are a little bit frustrated, because there's this kind of statistical ambiguity. That being said, could it be possible that this is real? And the answer is yes. Is it real? That real? No. Do I feel like we could cause harm by using Parp, especially in tumors that have seen a lot of prior therapies? I do, especially in BRCA. And we've seen that in a study called SOLO3, which was another treatment study, Parp versus chemo, only in patients with BRCA. And they had been heavily pretreated, at least 4 lines of therapy in over half the patients when they came on. They'd never seen a Parp. And so they looked at baseline before either arm started for what are called reversion mutations in BRCA. If you have a reversion mutation in your BRCA, which are caused by treatment, chemo doesn't, then you basically have a normal BRCA gene, and so you're resistant to Parp, and you can be more resistant to platinum in the recurrent setting. That is known. So both arms had about 3% reversion mutations because these patients' tumors had seen a lot of chemo, 3%. But on the olaparib arm, you can see this in blue, and the green part of that pie are the reversion mutations that occurred during participation on that study, so 18%. So you took tumors that had seen a lot of chemo, and then you gave them a Parp, and they already had an underlying BRCA mutation. We induced a mechanism of resistance. So I think the truth is somewhere in the middle. And now that we're really following much more closely overall survival and looking at these molecular biomarkers, I think we'll figure out the truth. But right now it's a little bit of a frustrating no man's land, and it's led to a lot of retractions, which I think are unfortunate for our patients. So in conclusion, though, what would I take from this? One, the best place to use a Parp inhibitor is frontline. And if a patient has high-grade serous or high-grade endometrioid ovarian cancer and they're in response to their frontline chemotherapy, you can use right now on label niraparib for any biomarker. You don't have to test. If you know someone has BRCA, you can use olaparib or niraparib. And if you know someone has HRD tumor, whether or not it has BRCA, you can use bevacizumab and olaparib. So that's true. We've definitely seen signals of cure, signals of overall survival benefit in biomarker positive populations. And this is the setting where we should be using Parp 100% in BRCA. For patients who've not seen a Parp and they recur and they're sensitive to platinum and respond to that next platinum, Parp inhibitors still are recommended here with counseling. Olaparib is still on label for all patients who are in response to that platinum. But of course, the benefit is most in biomarker positive. Rubraca and niraparib are only currently authorized for BRCA in that setting. We are no longer, in the third bullet, no longer recommending PARP inhibitors for use as treatment instead of chemotherapy. Certainly, you know, if I had a patient that came in that had never seen a PARP and was BRCA positive and for some reason, you know, couldn't get platinum, maybe she had an allergy, I would have a conversation with her about risks and benefits and kind of the ambiguity about the data, and we'd make a shared decision. But that would be off label now. So you just have to know that. But with that, I will stop. I know I went over. I hope I didn't talk too fast, and I'm happy to take questions during the question and answer session. I appreciate your attention.